While you're finishing up a chart for a patient, you hear somebody yelling, "Delivery in the ambulance bay." You run over, you realize that a patient has delivered and that there's a baby that you know how to take care of. And you wonder, how do I make sure that this neonate is okay?
Once you've gotten that emergency settled, the next patient you pick up presents with ultramental status, and you learn that they have had a VP shunt placed previously. And you wonder, is this something related to their shunt?
In this episode of Critical Decisions in Emergency Medicine, we will talk about emergency neonatal care, specifically at birth and within the 28 days after that.
We will also discuss increased intracranial pressure, specifically related to non-traumatic causes.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the May 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the critical procedure, critical cases in orthopedics and trauma, and the critical image.
And for our first lesson of this issue, we have Time Bomb, Acute Nontraumatic Increased Intracranial Pressure. Thank you to Doctors Arvind Jandoria, Trishna Dave, Aaron Hogue, and Bernard Lopez for writing this article. You know, Wendy, we think about elevated intracranial pressure with like severe traumatic brain injury, large intracranial hemorrhages. Are there other things that we need to be thinking about when we think of elevated intracranial pressure?
Indeed, there are definitely other disease processes that can cause elevated intracranial pressure too. And I think what makes it tricky sometimes is that these patients may not be presenting hyperacutely with their symptoms. And so maybe it is somebody who's had a VP shunt before and presenting with a VP shunt malfunction and having progressive worsening headache and ultramental status. At the crux of it, we think about what is really driving this elevated intracranial pressure. And it's that there's only so much fixed space that we have in our cranium that has to accommodate the brain, the blood, and CSF. And if one of those compartments or something in addition to those 3 elements are trying to vie for space in this fixed cranium, then we could deal with elevated intracranial pressure and ultimately lead to decreased perfusion of the brain.
Great reminders. And just to make sure we're all talking about the same thing, when we're saying elevated ICP, we're talking more than 20 millimeter of mercury. And that's the problem because it worsens cerebral perfusion then. All right, well, going back to our acute hydrocephalus patients and shunt malfunction and so on, what is our diagnostic workup for those patients?
A lot of it is going to be driven certainly by the patient's history and their presenting symptoms. And so, of course, if they're really, really severe in their presentation, they could present even with the Cushing's triad at the verge of herniation. They could also present with focal neurological deficits. But if they are not presenting in such emergent states and you're worried about their ICP being potentially elevated, the key is to do, of course, a thorough exam, including an eye exam, which in this case requires fundoscopy, or you can use your ultrasound to measure the optic nerve sheath diameter as generally a screening tool. Beyond that, though, of course, imaging is needed, and oftentimes we are going with a non-contrast head CT since that's readily available. And that can be helpful to assess the ventricular size, look for things that are obviously obstructing flow of CSF, look at if there is a VP shunt in terms of if there's any obvious malfunction or obstruction or trouble with its integrity. And then also some other signs that can suggest elevated ICP are midline shift, signs of herniation, general swelling of the brain, loss of gray white differentiation. Oftentimes, though, in patients with VP shunts, we also consider getting X-ray imaging to try and figure out if there could be some sort of a shunt disconnection or malfunction in other portions of the body. Now, one particular disease process, though, is idiopathic intracranial hypertension. And as we know, these patients could have very normal appearing CT findings. And really to diagnose this, it does require a lumbar puncture to measure if there is elevated ICP. They can also have some quite characteristic findings on their MRI, like some flattening of the posterior globe or even finding of transverse venous sinus stenosis.
Got it. So, how do we manage patients with elevated ICP?
Well, definitely we approach these patients the same way in terms of our ABCs, and maybe also important to remind everyone that brain injured patients really we want to avoid hypoxia and hypercarbia since both affect cerebral perfusion. And so if you are intubating a patient for airway protection, you do want to again ensure to avoid hypoxia and control their ventilation. In choice of RSI agents, ketamine was previously thought to elevate ICP, but that's really been debunked. Lidocaine was previously considered as a potential neuroprotective agent in terms of pre-treatment, but it's also not utilized anymore. And I think a key thing in the controlled ventilation is that when we use hyperventilation to reduce ICP by causing vasoconstriction, we don't want to do it for a prolonged period of time because we could end up causing cerebral ischemia. You can also use osmotic agents to decrease ICP. And really, if we're dealing with somebody who has acute hydrocephalus, especially if there's some sort of shunt malfunction, then we need to consult neurosurgery because they need to decide whether or not this patient may need some sort of an external ventricular drain.
Well, thank you, Wendy, for going through this very focused and high yield review of conditions that cause increased intracranial pressure other than just head bleeds and trauma. Specifically, we talked about hydrocephalus, VP shunt malfunction, and idiopathic intracranial hypertension, the importance of doing a good exam, an appropriate workup, and how to manage those patients. So, moving on to our critical ECG this month, we are continuing the pattern of discussing how to interpret an ECG for acute myocardial infarction in the presence of left bundle branch block. And we did talk about that a little bit last month about Scarboza criteria and how that can be evaluated for an ECG. And we continue the discussion in this issue. So take a look.
For our clinical pediatrics this month, it's a 14-year-old boy who presents with mucositis and conjunctivitis along with a fever, and you learn that he's had a recent influenza immunization. And the symptoms persisted and even developed some blistering mouth lesions, so they present to the ED. And you find that they end up having a positive IgG and IgM panel for Mycoplasma pneumoniae.
Reactive infection mucocutaneous eruption, or RIME, is mucositis that involves two or more mucous membranes. Although Mycoplasma pneumoniae is the most common cause of RIME, it can be triggered by various bacterial and viral respiratory infections. All we need to do for that is supportive care, and in severe cases, topical and systemic corticosteroids have been used.
Interesting. Definitely check out some of those pictures.
For our literature review this month, we're reviewing McCabe et al.'s article entitled Risk of Delayed Intubation After Presumed Opioid Overdose in the Emergency Department, published in Annals of Emergency Medicine in 2025.
I think as emergency physicians, we're definitely very familiar with opioid overdose and how to manage this. It is, of course, a major public health crisis. Now, the challenge is that some patients may be presenting with various types of opioid overdose, and some of those may have prolonged symptoms and complications. And this particular secondary analysis of the Fentalog study really looked at patients who are presenting once again with opioid overdose and trying to figure out, do any of these individuals have any delayed complications? And they found that if the patient does not immediately require ICU level of care at presentation and they're monitored for at least 4 hours in the emergency department and remain stable enough for a non-ICU setting, the risk of delayed complications, such as needing delayed intubation, is quite low. So that could help us provide some framework on how long to observe a patient to help assess the level of care needed.
Great summary for a great article. Our critical procedure this month is about informed consent for pediatric patients. Last month, we discussed the general concept of informed consent, and this time we're discussing specific considerations in peds. Important considerations include parental permission, pediatric assent, and the situational context, such as the patient's ability to express wishes for substituted judgment. Some things that can arise that can make this a little more complex as well is that the guardian may not demonstrate capacity or their choice is inappropriate or suggests child neglect or abuse. For example, in some situations, even withholding treatment from a child because of religious belief may be considered neglect or abuse. And that's why this may be quite complex to navigate. It's important to remember that adolescents are able to consent and make decisions for their own care when it is related to sexual activity, and that pediatric patients who are married, live independently, support themselves, or are on active duty in the armed forces may be considered emancipated minors and therefore be able to provide informed consent independently.
You also mentioned the concept of the patient, even though they may be of pediatric age, to providing assent. And so, while of course parental consent is required, if possible, the child should still be involved in the decision making process if they're of the age to understand. Now, in medical emergencies, when life saving treatments is necessary, the patient, as well as the parent, of course, should be told of the procedure's necessity rather than given the option to prevent assent. Now, moving on to our critical cases in ortho and trauma this month, it is a 19-year-old who unfortunately was a restrained driver when he hit a light pole, had loss of consciousness, and presented via EMS complaining of upper back pain and is not able to move his lower extremities. And you find that he is paralyzed of his bilateral lower extremities and also has sensory loss from his abdomen and neck downward.
Traumatic spinal cord injuries are more common in younger men, as well as due to falls in older adults. Spinal shock can present as a sudden transient depression of all spinal cord functions below the level of injury. Neurogenic shock, however, is different. It's a distributive shock that happens because of a combination of hypotension and bradycardia to distinguish neurogenic shock from other types of shock, and that usually happens when a spinal cord injury occurs above the T6 level. HLS principles should be followed while caring for patients with spinal cord injuries. It's important to remember that spinal motion restrictions must be maintained, and the American College of Surgeons best practice guidelines advocates for a MAP goal of 85 to 90 millimeter mercury. Methylprednisolone is no longer a thing. It hasn't been for a very long time, and various neurosurgical societies have recommended against that. Our critical image this month is a 46-year-old male who is presenting with 3 years of anterior neck swelling that has gradually worsened and feels that the pain is extending to his anterior chest. And now he has shortness of breath during activities. A CT of the neck with IV contrast is obtained.
Yeah, and some of the images shown in this feature definitely demonstrates a visible, palpable neck mass, is suggestive and concerning for a goiter. And that certainly is part of the differential for anterior neck mass, but we should also consider other sort of neoplasms, also parotid gland lesions, adenopathy, vascular lesions, as well as even soft tissue infections like Ludwig angina. Oftentimes, we do get imaging to try and better differentiate what the mass is, as well as evaluate for potential complications like compressive effects of the mass and get a sense of the extension anatomically. Now, when we are suspicious for goiter, the American College of Radiology recommends ultrasound as the preferred first-line imaging. However, depending on the size, extent, and maybe the patient's presenting symptoms, you can also consider a CT. And in this particular case, if you were to get a with IV contrast, it would not interfere with the goiter diagnosis. Specifically, cases where IV contrast may need to be cautiously considered would be patients who have known hyperthyroidism and presenting with concern of thyroid toxicosis, or if they need imminent radioactive ablation or radionuclide imaging for conditions like thyroid cancer. So definitely some great pearls from this section.
So for our second lesson of this issue, we have Breath of Life, Emergency Neonatal Care. Thank you to Doctors Dominique Diggs, Timothy Mock, and Elizabeth Collier for writing this article.
Danya, I find that neonates are the scariest patients that show up to the ED, especially if you're not a peds ED.
I absolutely agree with you. Whenever I see a number that looks like it's less than 1 month, or technically 28 days, right? Then I am just so scared because you never know what happens with these patients. However, one thing we really need to remember as well is that sometimes they don't actually show up as that. They actually show up in their mother's belly who delivers in your emergency department. So that's something to keep in mind.
That is very true. All right, let's say we have that situation. They are born in your ED and they start having respiratory issues. What do we do?
So it's important to recognize when something looks like a problem. So if the patient, the baby, is having respiratory distress, tachypnea, nasal flaring, grunting, retractions, and there's multiple causes for that, right? Some can be just transient tachypnea of the newborn, which is just part of them coming into the world, or, a problem like they aspirated some meconium, they have a respiratory distress syndrome or something like that. But what's scarier than that is having respiratory failure, where it's not these signs of respiratory distress, but rather they're unable to breathe effectively on their own. They have periods of apnea, bradypnea, they are gasping, or you note irregular breathing. And those are ones that need emergent interventions. We don't tend to review the neonatal resuscitation program or NRP algorithm often because we don't see it often. But just a couple of reminders is that when you see a baby looking like this, you need to warm them, clear their secretions the best way you can, whether it's bubble actual suction, and stimulate them, rubbing their back, the soles of their feet, drying them well, and then see. If they don't improve, then at that point, you need to start bagging them or put them on CPAP. Now, even if the patient is spontaneously breathing, you may need to do that if their heart rate is below 100 beats per minute. That is your first step in babies that age. If after you do all those interventions, you try to bag them and their chest rise is adequate, but their heart rate is still below 100, you need to intubate them. And something we tend to forget when we work with a lot of adults is that a heart rate below 60 means you start chest compressions with ventilated breaths in this population. After one round of that, if it continues to be below 60, that's time for epi. So again, very different algorithm than our older babies or adults.
Absolutely. Now, what about the scenario of a neonate born to a mother with a placental eruption?
So for these patients, you still need to follow this algorithm that we talked about with its breaths first and then chest compressions and then epi. And then when you get to that epi part with these patients, you do need to think about giving a volume expander because it's possible that they have hypovolemic shock, which is causing them to be in distress. Something to keep in mind with these kiddos at this age is that, especially if they're preterm, you need to be very careful with fluids because if you give boluses or rapid infusions or lots of fluid, which what you want to give is 10 cc's per kilo over 10 minutes, if you give them more than that, there's an increased risk of intracranial hemorrhage. And something to keep in mind as well is at this age, getting good IV access is probably not going to happen, especially if they're preterm. So these are patients who would need umbilical vein catheter insertion for their resuscitation.
That makes sense as well. Now moving on to maybe a less scary topic, neonatal jaundice. What causes that and how do we manage this?
So neonatal jaundice is when your total serum bilirubin is greater than 5 and can be unconjugated or conjugated, indirect or direct, right? Now, if it's conjugated, it's always pathologic. If it's unconjugated, then it could be physiologic or it can be pathologic from like hemolysis because they have some sort of enzyme deficiency or a syndrome like Gilbert syndrome or Crigler-Najjar. And if it is conjugated, then as we said, it's always pathologic. And you think of infections. That's your big thing, like torch infections, UTIs, sepsis, and so on. Thankfully, the most common one that we see is the non-pathologic, unconjugated hyperbilirubinemia, which is your physiologic jaundice, breast milk jaundice, breastfeeding jaundice, all of that stuff. Hopefully, we don't see that in the emergency department much because patients would have a pediatrician to follow up with. But hey, you never know. Basically, breast milk jaundice is a diagnosis of exclusion after all of the other causes have been ruled out. So basically, if you are stuck taking care of a baby because for some reason they're not at their pediatrician's office, the first thing is they need to get their levels and see if it's conjugated or unconjugated. And if it's unconjugated and it's physiologic is what it appears to you, you got to plot it on the prediction tool. Do you remember those, Wendy? We try to figure out if they're below the line. So then they get to go home. And if they're above the line, then they have to go to phototherapy. Of course, if the numbers are really high or if it's conjugated, then you need to start doing your whole workup and do your hemolysis labs and all of that and look for infections.
Got it. Now, in terms of seizures in this tiny sized population, is there anything we do differently?
Yes, so we have to keep an eye out for seizures because they may not look as obvious as we think. They may have subtle seizures where they look like they're pedaling or swimming, in addition to like clonic, tonic, myoclonic. And in this population, most likely you will find a cause. And it's only a small subset that has idiopathic seizures. Causes can be things like electrolyte derangements, infections, intracranial hemorrhage, or hypoxic ischemic encephalopathy at birth. The biggest tip to remember with managing seizures in this age group is that phenobarbital is your first line, not something that we do in other populations.
Very true. Okay, let's chat a little bit about neonatal sepsis. When should we suspect it?
Well, neonatal sepsis is really classified based on the timing of the onset. Early onset is the first 72 hours, and that's usually from transmission from the mother. We usually don't see those. The ones that we see are the late onset sepsis. And the biggest thing is that you have to have a very high index of suspicion because they can present with anything. If they look at you wrong, you should suspect that they have neonatal sepsis. And those are the patients that would get the full workup. They would get your urine, you will get your LP, you will get your chest x-ray, you get your blood cultures, and you would automatically treat them. Now, that is the case for those that are ill appearing. What has changed since I was in residency is that the AAP now has guidelines on how to evaluate children or neonates who are febrile but are well appearing. And in this case, those that are from 8 to 21 days are treated differently from those 22 to 28 days. So like your older neonate, you're almost going to stop being neonate. So in these cases, first group, you would get the urine analysis, urine culture, blood culture, CSF studies, lumbar puncture, inflammatory markers, and you would work them up. If they are older in that 22 to 28 days, you can hold off on the LP if their inflammatory markers are not considered elevated. So definitely worth looking at what those numbers mean, what exactly defines that as per the AAP, because that's a little different from what a lot of us have learned.
What about specifically neonatal meningitis? When should we worry about this?
So we'd usually worry about that in the same ones we'd worry about neonatal sepsis that are ill appearing. So if they are febrile, if they're not acting right, they're not as interactive, they show abnormal activity or seizures, they have poor muscle tone, and so on. And those patients, we would definitely want to do a lumbar puncture for them, and we would want to treat them empirically with antibiotics as well. And note that the dosages for antibiotics for suspected neonatal meningitis, the antibiotics that you would choose would be different from this general neonatal sepsis, because you'd want to test and think of HSV, especially if they have risk factors. And the antibiotic dosages, as we noted, are different. So definitely worth reviewing this information if you are facing a child with these symptoms.
Well, thank you, Danya, for taking us through this lesson. There are definitely a lot of pearls and also a good reminder on referring to some additional resources, such as the fact that we should always think about respiratory support in patients, in neonates presenting with respiratory failure or even bradycardia, since respiratory is often underlying etiology of that. In addition, if you are managing a neonate with jaundice, differentiating what type of hyperbilirubinemia will help you figure out how to manage it based on the AAP nomograms. And a good refresher on the AAP age-specific guidelines on neonates presenting well but with fever will help hopefully guide your workup and disposition. And don't forget about meningitis and neonates presenting ill and covering HSV in those situations.
Great summary. Moving on to our drug box this month, rimegepant for migraines.
We definitely talked about calcitonin gene-related peptide receptor antagonists before, and rimegepant is the first and only dissolvable oral tablet, so it really has a lot of potential in the ED setting. And studies have shown it's superior to placebo for pain relief and freedom from other bothersome symptoms. And so if we were to use it, it is a 75 milligram oral single dose with a max 1 dose every 24 hours. Just be careful in those with renal and hepatic impairments. And of course, it's not been studied in pregnant or breastfeeding patients.
And last but not least, our Tox Box this month is about North American coral snake envenomation. Those are the ones that are red, often with black spots, and yellow rings in contact with one another. They also have a black snout. Not sure how much you're staring at these snakes after they bite you. Or if your patient brings them to the emergency department, maybe you shouldn't be staring at them and should be running away. And remember, they can still bite when they're dead.
Yeah.
Yeah.
Just a picture is sufficient. A blur, I'm sure. A colorful blur.
I know. I'm like, can you just take a photo and leave it there?
Can AI identify it for them and then leave them out there?
I would not be surprised. Where are you? I was trying to get ChatGPT to tell me what snake this is to see if I should be here. But hey, if somebody, whether you or an artificial intelligence situation, identified a coral snake envenomation in North America, then remember that these patients can have delayed systemic neurotoxicity with neuromuscular weakness and paralysis, which can lead to respiratory failure. At the moment, pre-hospital, you need to do pressure mobilization bandage to impede lymphatic drainage. And to treat or hopefully prevent the neurologic symptoms, you can use 3 to 5 vials of the antivenom. If the antivenom is going to be delayed, then you need to administer neostigmine with glycopyrrolate to help control the secretions. And of course, these patients do not go home. Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle at Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
Bye-bye.